Hi everyone, I'm Dr. Deeksha Pandey and you are watching Urogynecology for Beginners. Today we have got you a different kind of series which we are going to start. First of all, I want to really thank you from the bottom of my heart for watching our videos, for liking those and commenting those. Actually, it really encourages us to become better and do something new and useful every time. So this time what we are going to do, we have picked up few questions. It is not possible. There are so many questions and we have 189 videos now and there are so many questions. It is not possible to take all the questions together, but we have picked a few questions. It is not that your question was good or your question was not good, but whatever caught our sight first, we just picked up those questions. And don't forget to write in the comment that how did you feel about this session, and if you want these kind of sessions more to be addressing other questions also, we would really love to do that, but we need your comments in the comment box below. So Vritti,
Yes,
and Dheera also, these
Yes,
are
ma'am.
both our fellows at Manipal Urogynecology.
First
And
fellows.
First
Yes.
fellows at Manipal Urogynecology. And they will be asking me questions, and as far as possible, I'll try to answer those questions today. So can we start?
Yes,
or you
ma'am.
want to read some comments before we start?
All right.
To
Okay. Yes.
increase the little warmth of the session,
Yes.
not just bombard me with questions. You can just read some good comments also. That
course.
will be interesting.
Yes,
Yes.
ma'am.
Ma'am, we have Mr. Siddesh Rajwade who says, who extends his who is very grateful, ma'am. He says, thank you so much for all your efforts in teaching youngsters. And ma'am, your videos are very crisp and very informative.
Our videos.
Yes.
So it is a combined effort, and Dr. Rajesh, I'm very thankful to you for watching the videos and then having the patience to comment also. We really appreciate it. It will help us to improve further, your encouragement.
Then, ma'am, there is a comment from Mr. Safo. I hope I'm saying your name right. So my apologies if I'm not. All the way from Ghana. They say thanks so much and following each and every video.
Oh, wow. Wow. Thank you so much. I think we should thank you and keep following us. We'll try to bring more interesting stuff in our channel.
Ma'am, we have Mrs. Swati Solanki who she asks a question like, do we have any short-term courses or hands-on courses in urogynecology coming up?
This is the question I think many of you have asked, and we are working on it. Things are not looking like it is not very easy to have short-term courses. An online course, actually, they'll say I wanted to do some online courses, but things are not working out. There are so many issues which we are working on, but we have not given up. We are still working on, and but keep following our channel, because whenever we are ready with some straightforward or concrete program, will definitely let us know. This channel will be the first one where you will come to know about all our programs, all our conferences. So maybe I can tell you, yes, I think this is a good opportunity to tell you that in October, 1st and 2nd of October, we are going to have a conference. You can think it is a shorthand on workshop itself, because we are having some number, we'll tell you the number, 10 or 20 students we will allow to operate, to do vaginal hysterectomies, to do TVTO, and to do retropubic tape also, in those models which are like human-like models.
Like
Yes. So we will do it in small sessions. So you can keep following us. Maybe in February we are going to open the
update about
registrations.
that. Yes. Should we start with the questions, ma'am?
Oh, I'm scared, but you can ask. Don't ask me tough questions.
Ma'am, we have a question from Seema Gautam. Her question was, while doing a vaginal hysterectomy, will giving a head low position prevent a rectal injury?
Okay. So I think this is a very interesting question. So what she's trying to say that many people, when you are opening the pouch of Douglas, people tell to give head low.
Right.
The idea is that when you give head low, the bowel moves up. And I had a friend some time ago. She told me she was working in some other institute before, and she said that her ma'am who used to operate was so particular of this step that she told if the assistant forgets when she's reaching that step while doing the surgery, her assistant has to tell, it was a must to tell the anesthetist to do head low.
Head low.
If you forget to tell that at that particular moment, she'll throw you out.
Like
Oh,
make
She
you
was
scrub out.
scrub
Yes.
out.
Oh
Yes.
God.
It was so important. But the thing is, I feel you can do whatever you want to do, but you must understand why you are doing what you are doing.
Right.
So why you are basically making the patient to be head low or making the patient head low, because when you are opening the pouch of Douglas, you are worried that the content of pouch of Douglas are small intestine, and when you are holding it, cutting, you might injure the small intestine in that step. The thing is, now when you know that your purpose is to make the small intestine go away, so what happens is small intestine, if it is free, like in normal situation, when you are making the patient head low, it will slip away.
Right.
But think of a situation if the small intestine is adherent. Even if you give, and this is a blind surgery, it's not
Yes.
that you are seeing from abdomen that what
Right.
is adherent and what is not. You are blindly opening the pouch of Douglas. Even if you make the patient head low, the intestine is not going to slip away, it
Move
is
up.
going to stay
Yes.
there. Okay, and then there are more chances of
Injury.
injury to the
Yes.
small intestine. Now, what we always teach, I think it is a very simple and very nice technique which I have also worked on after a lot of experience, that the best technique according to me to open the pouch of Douglas is tent ending. What you are doing when you are tenting, you are holding with a cocker, straight cocker, we hold the pouch of Douglas and pull it towards ourselves. So what happens when you do this, the U-shaped pouch of Douglas becomes V-shaped.
V-shape.
And because of this dead space, intestine cannot go.
Right.
Intestine will move, or you are moving away from intestine
Right.
before you are opening. And in this, if the intestine is adherent, that tenting will never happen.
Yeah.
So you will get an idea that here the intestine is adherent. It will not lose its shape when
Yes,
you are
ma'am.
trying to tent
Right.
it. So I think if you want, you can follow this simple step of tent ending, and it works.
And that's what we do.
Yeah.
The only thing that you can follow whatever but you have to think why you are doing
Yes,
what you are
ma'am.
doing.
Right.
Ma'am, there's another question by Miss Meena Kakolu. She has asked that while opening the pouch of Douglas, if the incision points towards the cervix, how to proceed after that?
Okay, so first thing I always say that prevention is better.
Mhm.
We should be away from cervix.
Yes,
we have to nick it in a free area.
Yeah.
Okay.
Right.
So what do you do with that? First, you have to tent and nick is good. If you are
Yes.
confused in your initial cases, there is a small formula.
Okay.
And you know the formula that when you are giving anti-incision,
Anterior, yes.
it is, if you are totally confused, where should I put my incision? Just follow me. Go 1.5 centimeters
Above
above
the
the
cervix.
above the external
External
os.
os. Yes,
Okay,
sorry.
and give. That is the cervicovaginal junction.
Yes.
And if you are having doubt where to incise posteriorly, just double
Double
it.
that. Yes,
Okay.
ma'am.
So if you have gone 1.5 centimeter anteriorly, how much you will go
3
posteriorly? 3
centimeters,
centimeters. Because pouch of Douglas is a more dependent area,
Yeah.
and you want to go away from the cervix, and it is a free area.
Yeah.
So if 1.5 centimeters, just double that, 3 centimeters you put a nick. Okay.
Yes.
And you don't be close to the cervix. Sometimes when we are doing initial surgeries, we are scared. I have seen many people who just keep on digging. By chance, if you have noticed, if you have realized that you are in the wrong plane, and while opening the pouch of Douglas, you are going into the cervix or cervical tissue, or in anterior also, this is the same thing.
Yes.
Once this realization happens, don't keep on doing this.
Yeah.
Okay, change your stop there. Analyze again, see what has gone wrong, and give another incision. Anyway, the cervix you are going to remove. So
Okay.
even if you have made one incision, doesn't matter. The moment you realize, stop there and reassess again and give a new
Give the
incision.
right incision.
Right
Okay,
incision.
Right. Ma'am, we have a question from Mrs. Ratna Folk who asks, ma'am, is ureterine stenting mandatory before a vesicovaginal fistula repair?
Okay, specifically she has asked about vesicovaginal fistula. Her answer is yes. And I'll tell you why also. I'm the person, I hope maybe, I keep on saying that for abdominal hysterectomy, whether it is for endometriosis or any other surgery, I don't prefer to stent the ureters. And why is that? Because if you imagine it, it looks very nice that once you will put the ureteric stent, the ureters will be easy to feel, easy to say. It is not that with normal gynae. Until and unless you are having that laparoscopic infrared
Yes,
kind of
ma'am.
glowing,
It gets
illuminating,
illuminated,
the
yes.
illuminating stents.
Yeah. If you don't have that, then it actually doesn't matter. In my beginning of my career, I have tried all this, and when I have done, even if you try to feel, it is a simple plastic tube what remains inside.
Very narrow.
Yeah. So it is not very easy. And what happens? You get confident, overconfident. Anyway, you have stented.
Right.
So there are chances of injury. Even the procedure in difficult cases, when you stent, when the anatomy is distorted, putting a stent is not that easy. So it might cause harm rather
benefit.
than
Actually,
causing
yeah,
benefit to the
prophylaxis.
patient. Yeah. So I always say in my videos also, I don't believe whatever you want to do, but I don't believe in stenting in normal hysterectomy cases. But for vesicovaginal fistula, yes, because when bladder is collapsed, okay, you will be working with empty bladder, and you are working in the bladder.
Right.
The vesicovaginal fistula is in the bladder, whatever distance it is from the trigone or from the urethric orifices. Then empty bladder, it will be not very far. Okay, it will be close. So maybe it is trigonal fistula or supratrigonal fistula. When you are freshening the edges, doing the dissection, creating the flaps, and closing it, there is a high chance that you might include the urethric orifices. And if you have seen in cystoscopy, the urethric orifices look very beautiful with a jet of urine coming out. But when you see it in an open case, they are very, very tiny pinpoint kind of things, not very easy to differentiate and very easy to be taken in a suture. You will not know. And when you are opening the bladder and when you are doing cystoscopy, it is very easy to see the urethric stents. So it is always better. It is always not better is not the word. I think it is important to stent the ureters if you are doing the vesicovaginal fistula surgery.
Yes.
Ma'am, there's another question regarding VVF only. So they have asked, this question is by Mr. Christian Rivers from Mexico.
Okay.
I'm asking all international questions.
Yes.
So I'm surprised and I'm happy and I'm humbled that we are getting
we have such
a
great reach.
Yeah.
Ma'am, so his question is that bladder closure should be done in one plane or two planes.
Okay.
And he's also asking that surgically, are there any points that we should take care of in order to prevent recurrence of fistula?
Okay. So this is in reference to again
VVF,
vesicovaginal
yes,
fistula. So in vesicovaginal fistula, this is a very interesting question. Whether should you repair bladder in single layer or two layers?
Yes.
So both the things are correct. Bladder is a very forgiving organ. Till few years ago, we thought that double layer closure is a must. But now the new literature and evidence says that single layer is good enough. Only one thing you have to keep in mind, that either you close in one layer or two layer.
Okay.
It should be watertight.
Yes, ma'am.
Okay. So you have to check for watertightness with the help of methylene blue. If it is watertight after single layer closure also,
We
that
can
is
stop
good
there.
enough. Yeah, this is the recent literature. The second part of the question is how to minimize the recurrence.
Yes,
So
ma'am.
we have told it in our video also, but I would like to repeat it also.
Yes.
Good dissection is the key, number one.
Yes.
Removal of the tract in between
Right.
tissue
Yeah.
so that
Excision,
it doesn't join again.
again.
Yes. Third important thing is that whenever you are suturing these two structures, the area of contact of two suture lines should be
Minimum.
as minimum as possible. So one suture you do one in the vertical and one horizontal,
Horizontal.
so that the contact is just one point. If you put two similar,
There's a
then
lot
the
of
entire
friction.
yes,
Yes,
entire area is in contact. And one more thing, would you like to tell?
Yes.
If you really want to prevent recurrence, then you
we
have to
place
put
an omental
Yes.
flap.
If you are doing it abdominally, you can place an omental flap. If you are doing it vaginally,
You can
you can
a
place
graft.
a
Marsh's
Marsh's
graft.
graft there. Okay, so something if there is in between the two organs or two viscous, it really helps in healing, better healing,
Yes, better
and
vascularity
and then recurrence will be less.
Yes, ma'am.
I think I have told all the points.
Yes.
And keep a catheterized bladder,
Oh,
which
yes,
post-operatively should be for long time. So bladder should be empty, because while during healing, if it opens up over distance, then again your surgical results will
Will be bad.
Yes.
Yes.
Ma'am, we have a question from Mr. Premji Chandran. This is in regards to a TBTO surgery. He says, are there any concerns for infection when the tape ends are left?
Okay. So I hope you are understanding this question. We in our surgery, I think we are the only people, or maybe if anybody has started following, I'll be happy. But I can say that we are the pioneers of this
Yes.
tape adjustment trick. So what we do when we are doing TVTO or TVTR, any of the procedure, we don't cut the
Cut
tape
the
then and
tapes.
there.
Yeah.
We keep it long for adjustment after 24 to 48
Hmm.
hours. So your concern is okay if we are leaving a foreign body which is coming from inside out, that might cause infection, but it will not cause scientifically because we keep it inside the dressing.
Hmm.
So it is like we are keeping, and the patient has got is usually in good antibiotic cover, so there is no risk of infection going inside. It is like when you put suture, metro sutures,
Right.
then you put dressing inside.
Yes.
The infection doesn't go from there. And if you want to go to another extreme, you can think of drain. When you put drain is coming out, it is
Yeah.
connecting. So it doesn't happen. And always don't keep it hanging, especially when it is TVTO. In the groin area, always keep it. It is just for one day.
Yeah.
So we put a dressing,
True shield.
true shield,
True shield.
small tree shield,
Waterproof.
waterproof, which we use for laparoscopic ports.
Ports
Same
also.
thing, we
Yeah.
keep it covered for 24 to 48 hours.
Hmm.
We have not seen any
Any
infection
infection
till
with
now,
that.
and we are
Cases.
hoping that we will not
Not
see
see
any
even,
infection. So it is quite safe, I think.
Ma'am, another question with regard to TVTO surgery. It is by Mr. Ketan Pandya. So he has asked, can we do a cystocele repair along with the TVTO surgery for SUI?
If the patient has
It has a
cystocele,
cystocele,
yes,
should it-
and
should-
SUI,
Yeah.
we must do
We
it.
must do.
In our setup in Indian prospect, I think Mary is from India,
Hmm.
and so was asking all about
International,
people, so I
questions,
thought
yes.
so in India, I think because of so many things, people don't come for follow-up, they don't undergo multiple surgeries.
Hmm.
So if you have found out that one patient who is having SUI, and on examination you find if she has a cystocele also, better to repair both the things in same sitting.
Right.
Why I'm saying so? Because in last 2 years, I think we have got 3 cases like that,
Hmm.
where patient went to the doctor with the complaint of SUI,
SUI.
and perfectly mid-urethral sling was put. Most
Yeah.
all the time it was the obturator pro sling was put, but within 1 year, patient came with bulge. So actually, what was happened when we asked the history more in detail, patient said that she had some kind of
Swelling.
cystocele before itself,
also.
which was not taken care of the time of surgery. Now, what is the pathophysiology of all this? SUI and actually they share the same
Right.
pathophysiology.
Yes, ma'am.
When the tissues around the structures or around the viscous become loose, then the urethra becomes hypermobile and causes
Correct.
stress urinary
Yes, ma'am.
incontinence. Similarly, when it becomes loose around the bladder, it causes cystocele. Now all the tissue around this lacks, okay, and patient is having also both the problems. And if you put a tape,
Right.
now one thing you have made tight, the other thing
All
is
the
still
weight,
loose.
Still
yes.
loose.
all
So,
yeah.
it's going to fall down more.
so the progression of cystocele is much
Faster.
faster once you have taped the patient.
Hmm.
So always take care of that in at least our setup, and patient will not come in after 2-3 months for follow-up or for surgery. Follow-up she might come,
Right.
but surgery if you tell she will not be ready.
Yeah.
Yes.
And here only I want to ask you one more question.
Yes, ma'am.
And that if you are doing both surgeries together,
Yeah.
should I give one long incision which starts from urethra up to the base of the cystocele?
No, ma'am.
No, ma'am.
So what incision should you give?
Ma'am,
Two
for the
separate
cystocele,
incisions.
yes.
Two separate
Okay.
incisions. Very important whenever you are combining. It's not that you dissect very good from urethra to bladder base, but rather you have to give 2 incisions, one for cystocele repair
And one for the tape.
exactly like the way we give for tape, which is 1 centimeter at the level of mid-urethra.
Mid-urethra.
Yes,
Because if you give long incision, it will
Tape,
slip.
just
Displace.
displacement.
Yeah.
Tape displacement.
If it goes towards the bladder neck, what is the problem?
Retention.
Retention. And purpose patient will go
Yes,
into
ma'am.
retention or this voiding
Voiding
dysfunction.
dysfunction.
Yes, ma'am.
And if it slips downwards, because
SUI will
Yeah.
be worse.
Yes.
it won't be
serve its
cured.
purpose.
Yeah.
It won't
Yes.
be cured. It will just lie there like a foreign body. It will not serve the purpose.
Yes,
So
ma'am.
both. So always remember that the incision should be around 1 to 1.5 centimeter in mid-urethra for
Right.
SUI and for mid-urethral slings, and then for cystocele, a separate
Yes.
incision, however we give it.
Yes, ma'am.
That That's
That's
are
it
the
for
questions
today.
for today, ma'am.
Oh,
Yes.
done.
I'm enjoying too
Yeah.
much.
We'll keep some for later.
Yes. So I really enjoyed this session of this
Yeah.
question answer thing, and I hope you also enjoyed and you got the answers to what you wanted to know. And so many international people we
People are
have,
asking.
and I hope you will get to see you. We are giving this time a long duration for
To
you
register.
to plan. Registration can be done in one day, but planning coming from other countries takes all sorts of problems. We realized it this time, and we are going to open the registration for MUC 4.0, which is our international conference with hands-on workshop.
Yes.
And you can register for it in the month of February, starting from the month of February, and plan your visit accordingly. The conference is going to happen in the month of October. To be specific, it is 1st and 2nd
First and
October.
second.
You can keep your holiday a little longer. We can suggest you some places to
Yes,
see.
to
around
visit.
also.
Yes, definitely.
Okay. So I think with this we finish today's session.
Thank you.
Thank you.
Thanks.
See you.
Keep watching.